Good morning to Pune and Punekars, and good evening to folks in the US, and good morning to everybody in India, and good whatever it is, wherever you are. And on behalf of AFMC alumni and friends, we welcome you to yet another edition of our knowledge exchange on behalf of Operation Breathe, which hopes to help Pune and Punekars breathe easier in the times of COVID. And really now, hopefully, in times after COVID, we hope. Today, we're having a very important conversation about long COVID. And I'm pleased to have Dr. Sitaram Subramani from Connecticut in the USA. And also, really, to join the conversation are our experts from Bharati Vidyapeeth, Dr. Purandare, and others. And we also hope to have some leaders in the administration from various places, Dr. Lalwani from Bharati Vidyapeeth, and hopefully we'll see Dr. Satyajit Singh Gill from Jahangir as well. As you know, what we have been trying to do is exchange knowledge. I want to remind you that this is not a webinar. This is not a grand rounds. Our didactics are short. The whole idea is that we have case-based discussions. And even during this time, if you have cases that you want to talk about, please, this is very informal. And remember, this only works when we all teach and we all learn. So we've had over the last several weeks, a number of physicians from the primary to the quaternary care setting in Pune, and had wonderful collaborations with Bharati Vidyapeeth. Sorry, that's a typo that keeps carrying on. Alumni of AFMC Pune from everywhere. We see Dr. Hazra from Command Hospital, Southern Command. And really physicians elsewhere on the front line of fighting COVID.
You're logging in. आप log in कर रहे हो? अच्छा हो? Okay, good. चलो, all right.
And Japaigo is an NGO that's been involved in capacity building in COVID. It was an essential partner on the ground for us, and Echo India, who's really making this whole thing possible. I wanted to ask Dr. Shinde, do we have any results from the Google Docs, that survey that you'd sent?
Sir, we have received some of the responses.
Okay. Do you want to briefly introduce, so if people haven't filled it out, they can fill it out, because if they're registered, they have emails for it. Do you want to briefly talk about that survey?
Yes.
Before we get started?
Yes. So, hello all, I'm Dr. Akash from Japaigo. So, we have developed a Google form and we have sent to all of you. I'll post a link in the chat box also. So we are trying to collect the information from you about what was your feedback of the previous session, and would you like to be an expert or want to present a case in the future session. Along with this, we are also assessing your needs in terms of capacity building of your nursing staff or any other technical support that we can provide through channelizing resources or connecting you with the right people. So I request you to all fill this Google form so that we can come up with a plan to support the COVID work that you are doing.
Thank you, Dr. Sinde. So if you haven't filled it out, please even fill it out even while this meeting is going on. So I'd like to move on and introduce our first presenter today, Dr. Sitaram Subramani. Dr. Subramani is an expert in physical medicine and rehab, and he'll talk to us a little bit about setting up a comprehensive multidisciplinary program for long COVID, and also present a case. And hopefully this will spark some conversation from a lot of other people who are doing this, people who are thinking about doing this. And so without much further ado, please, Dr. Subramani, you have to
Thank you, Dr.
stay.
Krishnamurthy. Thank you, Japaigo, and thank you, my colleagues in India. Good morning. It's a pleasure to be on. So I'm just hoping to spark a discussion about, as we call it in the USA, long COVID or COVID long haulers. I know you have been through the throes of a second wave in India, but this is what you will be seeing as a postmortem from all these patients who've had COVID infections. Maybe a little different in the majority of the symptoms than we see out here. I'm not very technologically sound, so I'm surprised I was able to do this. That's great. So, we were going through the throes of COVID and mostly treating acute patients till October, when in the national media, they started talking about this mysterious group of patients who were having persistent symptoms, having recovered from a COVID infection. At that point, our hospital system said, let's look at this and see what's going on and see if we can help these patients. So as we have been seeing more patients since October of last year, the definitions have changed, the length of duration of symptoms have changed. This was the latest guidance produced by CDC on June 14th, where they call these post-COVID sequelae conditions as an umbrella term to include a lot of physical and mental health symptoms which create significant life consequences. And they're usually 4 weeks after the initial COVID infection. So that's what the CDC is calling it now. When we first started the clinic, we were talking about patients having persistent symptoms 3 weeks post COVID, lasting for about 3 months. We have patients now who are still having symptoms 9 months post COVID. This was an article that came out recently, which seemed to split these patients in a much more scientific manner. So the short COVID patients are the patients that go into the hospital, have COVID symptoms, or have symptoms at home, but recover within 2 to 3 weeks. Then you have the acute, the post-COVID sequelae patients that we can divide into 2 groups. The ones that have symptoms between 3 weeks but less than 12 weeks. And then there is this group of chronic COVID patients that have symptoms past 12 weeks after exposure. So we started what we call, this is the COVID Recovery Center. The whole idea was to have a multidisciplinary clinic, holistically organized. So there are a lot of, we are providing a lot of integrated medicine, a lot of multidisciplinary care, and basically based on health and wellness of these patients, and also helping them return back to their regular life and to work. So the first thing was to have an entryway. So we created a single access number that the patients could call. The number was available from 8 a.m. to 5 p.m. Monday through Friday. These people were called COVID schedulers, and they would refer these patients to the triage team, which initially for the first 3 months was 4 primary care physicians. And as we found out, and I'm a little biased because I'm a physiatrist, we are more global physicians. We are very good diagnosticians. So a lot of the patients were being referred to us directly. So they made us a part of the triage team. So now it's a mix of primary care and 3 physiatrists. The requirement was that the patients have a positive COVID test and have no acute symptoms at the time of referral. They can be referred by themselves or by their referring physician. We had a specific template when we triaged these patients so we could share them or refer them to our multidisciplinary team. These clinics could be virtual or in person, which helped us a lot because Hartford Healthcare is mainly in the central part of Connecticut, and we are getting patients all over the state. We had a multidisciplinary team that consisted of pulmonologists, cardiologists, and physiatrists in the beginning, and it has slowly expanded, as you will see in some of my next slides. And each of these specialty providers gave us a clinical pathway that we could use to refer the patients to them, so they don't get inundated with inappropriate patients, so to speak. They also guaranteed priority access through their offices for these patients. the referrals to behavioral health, rehabilitation medicine, and rehab services, which is physical therapy, occupational therapy, and speech therapy, was expedited. So if you had a patient who was having significant issues with balance and deconditioning, they could be directly referred to PT, and we guaranteed that they were seen quickly. We are getting 50 to 60% of our patients having supratentorial stuff. That is, they have anxiety, they have sleep dysfunction, they have post-traumatic stress, and these people were referred immediately to behavioral health so they can start working with the support groups. We were also, as we want to share with you, is this is a new league of patients that we have. We want to collect the data. We are learning every day from every patient, and we hope to learn from your experience too. So we have created a registry of all these patients to collect the data and use it for further research. The NIH in the United States now has had a big push on COVID, post-COVID research. The goal here is a longitudinal care to evaluate the sequelae of the disease and what symptoms the patients are having, and provide them with treatment to enhance their recovery and function. So basically, how does it work? You have this sick post-COVID patient, calls a number and gets into the access center, and they are sent to the triage team, which is a primary care or PM&R. And then we follow the clinical pathway and make the referrals. The referrals go to our multidisciplinary team, which is pulmonary, cardiology, behavioral health, infectious diseases, rehab medicine, headache. We have a general neurologist who's joined our team recently, rheumatology, and neuropsychology. And I don't know if you can see this, we have some services that we can avail of: integrated medicine with acupuncture and massage. One of the big things we're using is auricular acupuncture for anxiety and sleep dysfunction, and also rehab services. Our behavioral medicine team is coming up with a support group for a lot of these patients. And obviously, we hope to make these patients feel better and they can live their life and return back to work. So each of our subspecialty providers gave us a clinical pathway. So pulmonary said it was persistent shortness of breath and with activity, chest tightness, discomfort with breathing, or an inability to take a full breath inhalation or a full breath exhalation. Cardiology said these have to be patients who have syncope, dyspnea, chest pain, and palpitations. Rheumatology, we started seeing some patients with joint pains, swollen joints, red joints, swellings. And at that initial point in October, we were not doing an evaluation of the inflammatory markers. So we are now on a standard triage looking at ESR and CRP. And if that is elevated and they have swollen joints, swollen extremities, we are referring them to rheumatology. Headache. Our headache specialists only want to see the new onset headaches. If the patient has a premorbid history of migraines or headaches, they usually have a headache specialist that they're already seeing, so they get referred back to them. Neurology will see anybody with weakness, numbness, visual disturbances, vertigo, aphasia, dysphagia, trouble concentrating, focusing, people with brain fog. And our neuropsychology will take care of patients who are having difficulties with thinking and memory. And our behavioral health providers, which are a big help for us, see patients pretty quickly, especially patients with difficulty sleeping, anxiety, PTSD. They do some patient-reported outcomes. PHQ-9 is a depression screen with 9 questions. It can be finished in 2 minutes by the patient. Drug abuse screen from the National Drug Abuse System, and the PTSD screen, which is a 4 questionnaire that can give us an idea of whether they are suffering from PTSD. And this is a validated measure that's used in our veterans system. Rehabilitation medicine is doing a PROMIS 10 evaluation. When the patients first come to us, it's 10 questions about quality of life, activities of daily living, doing the daily things, and how they are managing. And then once they are discharged, we hope to redo the PROMIS 10 to see if we have made a difference in the scores. In PM&R, we are seeing a multitude of patients with fatigue, myalgias, weakness, shortness of breath, chest pain with breathing, brain fog, difficulties with daily activities, and lymphatic edema. So we have had about, since October 25th, 2020 to June 11th, we've had about 1,800 referrals. We have seen 1,474 patients, predominantly women. And surprisingly, the average age of these post-COVID patients that we see in the CRC are 47 to 48 years old. They are patients who have had mild to moderate COVID. Some of them have been asymptomatic. Most of them have never been admitted to the hospital, and most of them have never needed supplemental oxygen. Rehab medicine has seen the most, about 320. Our classic symptoms are fatigue, myalgia, brain fog, and chest pain. Pulmonary has seen 237, and a common symptom with them is persistent shortness of breath and chest pain. In behavioral health, it's like I had said before, anxiety, PTSD, and sleep dysfunction. Neuropsychology testing has shown two major areas where people have problems in verbal speed and verbal recall. And cardiology, interestingly, hasn't seen any exotic patients. They haven't had any actual arrhythmias, haven't seen any significant myocarditis. Most of the patients they've seen have palpitations, and usually their 30-day loop monitor study is negative. They are seeing a lot of folks with autonomic dysfunction, and they are actually proposing a research study to evaluate that. So at this point, I just talked to a bunch of my ENT providers, and they are going to join our team. So I'm really happy about that, because we are seeing people who are having some issues with breathing and speaking. So their voice gets weaker, they get raspy after a while. We are also seeing folks who are lost sense of taste and smell, but they recover, but it's abnormal. So their smell and their taste is abnormal. And so ENT is very interested in seeing them. We have one ENT specialist who runs a balance center. He's really very smart and very nationally renowned. So he has been going to see a lot of our vertigo patients. I have a young semi-pro soccer player who runs a soccer camp, and right now all his symptoms have improved, but the minute he gets on the field, in 5 minutes, he starts getting vertigo and dizziness, and he can't play any further. His cardiac workup was negative, and his neurology workup was negative. So I'm really thrilled that the ENT folks are joining us. Dr. K, should I go with the first case?
Yeah, I thought maybe we'll give your voice a little bit of a rest.
Okay.
And we'll request a couple of people to share their experience. I'm just going to, Dr. Purandare, would you start? And then I see Dr. Chitralekha Khati here, and I might request if she's willing to share a little bit of her experience, just informally.
Hi,
Dr.
Chitti.
Purandare? Can you hear us?
Hello, everyone.
Hi.
Am I audible?
Hi, Dr. Purandare.
Hi. So good morning, everyone. And I don't
Could you
know.
stop
Yes.
sharing for a moment, please, Mani? So that we
Sorry.
can see Dr. Purandare.
So it was a wonderful presentation by Dr. Subramani, and I think he's still yet to complete his presentation. And I'm eager to see what his cases are. And it is really a wonderful sort of start to today's meeting that Dr. Subramani has done. And I wish everyone a very, very good morning. Am I audible?
Yes, sir. Yes, you are. Mhm.
So when I was told about this post-COVID, I thought that it could be post-COVID or long COVID. But when I searched the net, I found that these terms have been used interchangeably. So some people are calling it as a long COVID. Some people are calling it as a post-COVID. So ultimately, to summarize, that the patient is actually not well even after recovery from his COVID. His symptoms do continue. They do continue to interfere with the quality of his life. That's why the physician visits increase. So this is what actually post-COVID is. And we are seeing it in various forms. I've made a small presentation. If the organizers could permit me to show it,
Yeah,
maybe
please. Yeah.
8 or 9 slides.
Yeah,
There
go
is a
ahead.
theoretical technical part that I will quickly go through. And then the last most important part is two interesting cases, which I will quickly present in a few minutes. So are you seeing my slides? Is it
Yeah,
visible? So I think this discussion has already been done that if there are health symptoms lasting for weeks or months after recovery from COVID-19, then we call it as either post-COVID or long COVID. And we have to remember that this can be irrespective of the severity of the initial illness. So a person may be relatively well, home quarantined, or he may be very, very bad in the ICU, and then he may have recovered, and after that the symptoms persist after a period of time, and it could be either one symptom or a combination of various symptoms. So what symptoms do we see? What people commonly come to us and tell us when they have recovered from COVID? Why do they attend physicians? It is because of these symptoms. So most of them, in my experience, have fatigue. So many of them have fatigue that they say that, okay, when we go to work, we have to come back in 2 to 4 hours. We can't work the full shift, and then we have to take breaks. So even after they have recovered and they join their work, they will take leaves for the health reason. So fatigue is very, very common. I think that is the most predominant symptom in long COVID. And then we find this clouding of sensorium or headaches or loss of smell and taste, sometimes dizziness, sometimes palpitations as other common symptoms. Many of them tell us that their muscles ache, their tendons ache, their joints ache, or their head aches. They get breathlessness upon activity, and sometimes they get fever, or sometimes they get just a feverish feeling. So if you tell them to measure the temperature with a thermometer, they may not be able to, catch that temperature, but they have got that warm feeling, or they have got that sort of feverish feeling. And invariably, these symptoms will increase when they get exertion. So that's what they report. And a significant bit of them, I would say nearly 20-25% of the people have psychiatric symptoms. So they've got anxiety, they've got depression, they've got something which is similar to a post-traumatic stress disorder. If they've got a very bad hospitalization, they keep on remembering things during hospitalization. Many of them report that bodies were wrapped in front of them, and they could see the bodies going in front of them. So that was a traumatizing experience for them. We are, as doctors, used to that scene, but a general public is not used to see that scene. Or a patient by the side of them suddenly dies, and then they get that mental trauma and shock. So these symptoms go on for weeks or months, or even sometimes they can even cross 1 year. And in India, we find that there are additional syndromes in what we have just discussed. Like people get multiple infections in post-COVID period. I have seen repeated admissions happening with lower respiratory infections, secondary battle pneumonia, or repeated urinary tract infections, and then mycotic infections like Aspergillus and Mucor, they are on rise. So we are seeing that people after months are coming back with these mycotic infections. Then I've also observed that if the people were hypoxic at the time of their initial admission, and in the post-COVID or long COVID period, they get any other infection or any other syndrome, their hypoxia worsens. They become more hypoxic. So a person who was not on oxygen suddenly comes back to hospital casualty and starts requiring oxygen at 15 liters or by on NRBM or something like that. So I think they must have that underlying, fibrosis there, which just keeps on worsening with event of a new syndrome happening there. Then I've seen few patients who had multi-system inflammatory syndrome. So they just presented with fevers, muscle pains, body aches, and a lot of investigations could not reveal anything. And ultimately, we put them a label that, okay, you have got probably MIS-A, multi-system inflammatory syndrome of adults, and just put them back on steroids. And they did well, but I was quite skeptical while putting them back on steroids because the risk of mycotic infection in India is very high with repeated use or high doses of steroids. Then I've seen quite a bit of patients coming with thyroiditis and hyperglycemia during post-COVID phase. Anxiety, depression has been common. And this peculiar thing of vascular events post-COVID I have seen. So people have recovered and gone back and come back with stroke. People have come back with coronary syndromes. People have come back with peripheral vascular disease, gangrene of extremities, or even bowel gangrene, abdominal pains, bowel gangrene, pancreatitis. And so it's a I mean, a variety of syndromes can happen. So I would tell you that this point of time in the hospital in which I'm working, there are 40 COVID patients, but there are 250 post-COVID patients. So can you imagine the health burden that this post-COVID syndrome is producing onto us? So 250 post-COVID and 50 COVID, that is current ratio. So how do we deal with long COVID? So first of all, we have to recognize that there is such an entity called as long COVID or post-COVID. If that recognition is not there, we might just dismiss this is something non-specific symptom. This person is unnecessarily taking my time. But it's not so, my friends. They are real symptoms. Once you have suffered from COVID, the ones they will definitely understand that there are real symptoms. We may not be able to find reason, or we are yet to identify what this actual syndrome is, but there is something which we just cannot dismiss off. So first of all, we have to recognize that there is something called as post-COVID or long COVID, and we have to establish post-COVID OPD or some section of medicine OPD looking after this syndrome. If there is no recognition, this will go unrecognized. So I was very happy to hear from Dr. Subramani that they are approaching this with a multidisciplinary approach, and they are getting ENT people on board, they are getting rheumatologists on board, or they are getting some other people like neurologists or some headache specialists. So people should feel that my symptoms are being taken care of, rather than just being dismissing, this is nothing, you are unnecessary complaining. Yes, psychiatric symptoms can be 20-25%, but 60-70% would be organic. And I'll show you one or two cases in just last 1 or 2 minutes to sort of superimpose on your mind that yes, there is something called as long COVID, and it is a real syndrome. How do we investigate this long COVID? So it is generally a very non-specific syndrome, and you have to first of all evaluate their symptoms, do a brief clinical examination, and try and localize the symptoms to any one particular system. Then we can take that particular system and investigate that system in detail. In addition to that particular system where the symptoms are pointing to, we should do CBC, maybe hepatic renal profile, vitamin D level. In India, it's very, very rampant vitamin D deficiency, ESR, CRP, D-dimer, that helps, and cultures of appropriate places if you feel that infectious syndrome is happening. Imaging, so for evaluating a patient with COVID, we have gone up to PET scan. If we don't get the source of fever or so don't get the source of symptoms in a post-COVID person, we have done up to PET CT, but imaging of various organs such as ultrasonography, CT abdomen, CT chest can be done to investigate what are the reason of symptoms. And then, as Dr. Subramani pointed out some time back, a multidisciplinary approach. So it turns out to be a CNS syndrome, then neurologist chips in. If it turns out to be a rheumatologic syndrome, then rheumatologist chips in. If it turns out to have something to do with sugars or thyroid, then endocrinologist comes in. So that approach we have to take. So to summarize the long COVID treatment, I would say that there are 3 R's very important. Recognize the syndrome, reassure the patient is very important that his symptoms are being heard of, even if you don't have treatment on his symptoms, but at least hear the symptoms patiently, reassure the patient that most of them will be temporary, most of them will be probably recovering over a period of time. If he has deficiencies, replace the deficiencies, rehabilitate the person who has got any deficits in any of the bodily systems, and then of course specific therapy and follow-up is required for long COVID, because you may not recognize the syndrome initially and you might end up diagnosing it later on. So tell the patient that you please follow up, your symptoms do not abate is very important. I will present 2 short cases, 1 minute each. So one of these my patients were around 35 years old. A male had fevers for 3 weeks. He had recovered from COVID nearly 4 months ago. He was home quarantined. He had not much severe illness, but after recovery, after 4 months, he started getting fevers which persisted for nearly 3 weeks. He complains of weight loss, perspirations, palpitations, and fever was typical evening rise. So his general physician thought that this could be TB. So he referred the patient to me to the infectious disease OPD. I evaluated the patient. What I found was he had low-grade temperatures up to 99 and a tachycardia. And there was a significant tenderness on one of his lobes of thyroid gland with few tender cervical lymph nodes in the posterior cervical region. Evaluation suggested that he had leukocytosis, high ESR, high CRP, and a very low, nearly undetectable TSH. So I ended up diagnosing that patient as post-COVID thyroiditis. He underwent further evaluation and treatment with the endocrinologist. that could be a different talk. But so we ended up diagnosing him as post-COVID thyroiditis. The second case is quite interesting, a unique case in which this patient had a vision reduction 2 months after recovery from COVID. Now his COVID was really very bad. He was admitted in an outside hospital in an ICU. He was in ICU. He was on NIV for some time. Then he recovered and he received all sorts of drugs such as steroids, antibiotics, tocilizumab, remdesivir, and so on. Then he recovered, but 2 months after recovery, he found that his vision is reducing. And the ophthalmologist who was seeing him found that he has got actually endogenous endophthalmitis. So he did not suspect, but I started suspecting that this could be bacterial or fungal. So I requested my ophthalmologist friend that you please do the vitrectomy and you send it for various stains and cultures. And to our surprise, on the KOH mount and calcofluor, we could see this nice hyphae of aspergillus. I have not put the picture, but I could, I'm just imagining how it was. So it was that slender aseptate hyphae at an acute angle branching. So on smear only diagnosis of aspergillus endophthalmitis was made. We have done a CT chest of this person and we found that there was this halo sign, the nodule with the surrounding halo around it. So it was basically pulmonary aspergillosis with endogenous endophthalmitis causing vision reduction. So ultimately we put this patient on the specific angle therapy and patient is now recovering. So these kind of syndrome mycotomes are also very common in long COVID or post-COVID period. So I think that must have developed aspergillosis during hospitalization, was unrecognized, aspergillemia, and then he landed up with getting that of his eyes to get endophthalmitis. So it could cost his vision. So remember that post-COVID can be organ damaging also. So the symptoms may not be dismissible, saying that they are just related to psychiatry or something, but needs a close watch. At least 60-70% could be organic, 30 could be psychological or psychiatric origin, and they have to be follow up to diagnose the case correctly. So after sharing of this, I'll stop sharing my screen and let's take the discussion forward. Experts on the board.
Thank you, Dr. Purandare. Wonderful presentation on different aspects. And you point out that psychiatric problems are real, and it's getting in the way of people working, and also that we could miss organic problems, because if you're not watching. So two things I'd like to do. One, I'd like to recognize Dr. Sanjay Lalwani, who's the medical director at Bharati Vidyapeeth. Dr. Lalwani, welcome. And I hope you will join the conversation on how to organize a post-COVID multidisciplinary clinic. Welcome, sir.
Yeah.
And
thanks to all of you on the board. And even there was a request from Dr. Priscilla yesterday. So I think from the medical school in Pune, any form of support for this multidisciplinary business, which will help the clinicians at large and share our experiences with the colleagues in the group. So I will not hesitate to extend this support where it should become a truly multidisciplinary approach where all the states from all the specialties would pitch in, and we would take this discussion. I think I will, since Priscilla has taken the initiative and pulled in the faculty like Dr. Iyer, Dr. Purandare, I'm sure she has the right and I think we will pass on this message to all our colleagues in the medical school. 1 week prior or 15 days prior, they all could put up cases, discussions, problematic issues, share it on the common platform and get the expert opinion, because I think COVID as a whole has been a new disease, and post-COVID itself is going to be a Pandora's box. We really don't know what the patients are going to come, what complications they are going to. So we will go ahead and discuss all this thing at length. Since activity is a routine activity from the Indian perspective and from faculty of colleagues from abroad, we would take this discussion every day. I think Priscilla also mentioned me yesterday that she wanted to discussion on what are the pediatric aspect of COVID. So I think next time I could request one of our pediatric faculty, Dr. Bhakti Sarangi. We have had seen plus cases of Miss C, that is the post-COVID syndrome in varied manifestations. But one good thing is that them could be recovered and we have not had any mortality. And what are the manifestations which the children have presented? Now, COVID is going to be better in presentation of patients who are going to come with varied presentation. Is it just an association with COVID or COVID has contributed to it? I think it's going to unveil over years to come. So let us make this a common sharing platform. And I think what we should try to see that this platform pillar and try to reach maximum number of faculty. And it's the most program for people to learn every Wednesday morning from experiences, Pune, and experiences, of course, from the colleagues, and they can share. At the same time, I would also request that those people, if there are any queries to be asked, they put platform so that it's a part of not learning, but also getting their doubts clear aspects of COVID. I think this will go a long way in enriching faculty across the groups to understand the COVID. And from my side, I think it's a green channel for all the people. If medical school can contribute to it, I think it will be a wonderful experience.
Thank you. Thank you. Thank you very much, Dr. Lalwani. And just a pointer to the fact that long COVID exists in other parts of the world, including New Delhi. I'm going to call on Dr. Chitralekha Khati to please share briefly her experience, and then after that, Subramani.
Hi, Krish. Can you hear me?
Yes, you.
Okay. And I mean, I wasn't prepared to talk, but yes, I've had a hell of a lot of experience, yet to gather my thoughts. Compliments to Dr. Bharat for very well putting it all together. This is what we're all seeing. And infective comments apart. What I'm doing is side by side, I'm doing undergrad team. So infective complications in long COVID apart, strong feeling that there are certain HLA associations which in my setup we can't check. Certain very
Let it burn. Pay attention to the gas.
Share with you people is that I've been dealing with clusters in families. So I find that relatives who are not blood, like a husband-wife, the wife may have a different pattern, or if there is a mother-in-law in the house, she may have a different pattern of patient and long COVID both. Whereas people related genetically, they tend to have a similar presence of different severities. Side by side, I'm teaching undergrads, so I find that this entire spectrum of post-COVID, apart from neuropsychiatric and infectious complications, behaves like any other immunological disorder. And the drug, so every system affected. Well, how is it different from APL? I don't know. We are not doing these things. Antiphospholipid, we are just not testing for them. And we're sort of clubbing them. But yes, there is a need, like Dr. Subramanian, for an integrated center to come up, which will generate multi-data. But in resource settings like a government hospital, I cannot take the initiative. I can provide samples for somebody else to step forward from there. So definite association with HLA type, genetic markers, we need to do SM, anti-mitochondrial antibodies, so entire rheumatology profile we need to do in these non-specific immunology. That is my view.
Thank you. Thank you, Dr. Kati.
Yeah.
At a moment's notice, you just did a wonderful job sharing your experience. I really appreciate it. I hope we didn't burn your breakfast. So it was
I was, that's right. So
Thank you. Thank you.
Bye.
With conversation, I want to invite Dr. Subramani to present his case and then really conversation about how to do this. So over to you. I'll keep shut now.
Thank you. Dr. Kati, it's good to see. So one of the things, Dr. Purandre, your presentation was wonderful because see a very different population here. The infectious part is lower. It's a much younger population. And as you said, some of them symptomatic. I just saw a patient today who had COVID since October, was tested positive, had symptoms for about a mild fever, no shortness of breath, no loss of taste or smell. Within a month, got short of breath, fatigue, brain fog, accountant in an organization, couldn't do a simple math problem, and was significantly short of breath and fatigued. So she's still struggling with symptoms, and she's with our COVID recovery clinic. So the folks that we are seeing are people who are getting mild symptoms. One of the other interesting phenomena we are seeing here, and I've seen this anecdotally, I don't have the echo on it, when people are getting vaccinated, especially with our Pfizer and vaccines, a lot of them are recovering, going back to baseline, and their symptoms seem to resolve. It's not in 100 cases, but I would say a majority of the cases that I have seen who got vaccinated got better. So that's just another, people just talking to our ENT specialists who are joining our team, who was talking about whether they are seeing more incidences of labyrinthitis, tinnitus in patients. Is it related to post-COVID? Is it related to the vaccine? We don't know. Is it just coincidental? We don't know. Have to look at that data, but they are seeing a lot more of these patients in their ambulatory setting. So a classic case I wanted to present was a 24-year-old Caucasian female who around March 2020 was at a conference in Cambridge, Massachusetts, and was exposed. There was a ton of people there that were exposed, and she tested positive. She came home. She gave it to her parents. Her symptoms were shortness of breath, chest tightness, fatigue, and most of the symptoms lasted 8 to 10 days. She did not have any loss of smell. She did not have any initial problems with her cognition. 4 weeks, those symptoms lasted for about a week or 10 days. And then in 4 to 5 later, she started getting brain fog and losing concentration. Now, as you see, this girl was a student. She had just undergrad, and she had a offer to go to do her PhD at Cambridge University in England for a PhD in genetics. And she was going to study there in the semester last year. And she could not even read a research paper. She could not come and read 3 lines on a research paper. So she decided to postpone her enrollment into Cambridge. She had a lot of pre-morbid risk factors. One was prior to COVID, she had started putting on weight. She was diagnosed with polycystic. She also was pre-diabetic, was started on metformin. She had a referral nutritionist and a bariatric specialist about weight loss. She also had underlying history of fibromyalgia and chronic fatigue. So she was having a lot of difficulty with sleep patterns. And that was something that she had decided to postpone her enrollment into Cambridge. So she came to us to the COVID Recovery Center, a pulmonary referral. She had obviously got a behavioral med referral, and she saw rehab medicine, or physical and aerobic conditioning. We also went through speech therapy, and our speech therapists work in conjunction with physical therapists on breathing. They do a lot of breathing and speaking kind of coordination exercise. Also do some objective monitoring of MIPS and MAPS, and then just do the 6-minute walk and certain other objective parameters as they work with these patients. There has also been some literature saying that there is a risk element to the pulmonary infection with COVID. These all have a associated chest pain when they breathe. So an article that came out of actually Wuhan, China, where they were talking about some intercostal stretching exercises, which we have put together in our rehab world. So they go through these intercostal exercises, and this help expand their chest wall and help them breathe. We also put them through respiratory training, which is we have a special respiratory instrument that they can breathe in and breathe out and strengthen their. If they are not able to afford something like that, a simple incentive spur is covered by insurance. I would give them a script, explain to them how to use it. That's something they do 3 to 4 times a day. So that seems to help also. When a speech, along with the respiratory training, also do cognitive training, where they help figure out if this is a short-term memory loss. You keep a memory book. How can you work with certain apps? For this young lady who was very good with the phone and apps and stuff like that, they gave her multiple games to work with, and that's what she did through the. So these were repetitive exercises that she performed. I'm glad that at this point she has enrolled in the spring semester in Cambridge. We have a couple of virtual follow-up visits. She's doing really well in school. She feels like she's back to baseline from a cognitive point, and she's continues to work on our conditioning exercise. To 20%, that could be 3.3 million people. And the prediction is that 1/3 of these people will not return to work. And a lot of these people that we are seeing who have post-traumatic stress, significant persistent symptoms, are the frontliners in the COVID fight. The experienced nurses, APPs, PAs, and some of the providers. And so that's making a big difference in our healthcare system if these experienced people are not returning to work because of the effects of COVID, which leaves us with younger and inexperienced practitioners in very critical areas of the healthcare field. So that's why it's very significant at this point, not only from a healthcare standpoint, but from a healthcare economic standpoint. I will stop talking at this point, Dr. K.
Yeah. Thank you, Dr. Subramani. So a couple of things. We've had a lot of important conversations. So clearly, if young people, right, even in an environment when there is no unemployment insurance, social security net, people are not able to go to work. This is urgent and important. So if because you actually walked this walk of putting together a multidisciplinary program, do you have a sense? It was really wonderful to hear Dr. Lalwani say, we have your support. But if you were to say, how would you start a multidisciplinary program? Do you want to share a few things? And then there's a bunch of questions which I'll just read out to you, and then, rapid fire, see what answers you have.
Is this for me, Dr. K?
Yes.
Yeah, so obviously, we are the spoiled Americans, right? So we have a lot of resources. When we got in, we just, within 1 week of our CEO asking us to set up this clinic, we were able to get it started. But like our discussion yesterday, the first would be having a registry, where Prissy and we were talking about, is having a registry of these patients and educating them that they might have had a pretty bad event with COVID, admitted to the hospital. Now they are home, they've had all that PTSD. They don't want to go back to the hospital, but they're still having symptoms, and they don't understand that these symptoms are post-COVID. So it's a matter of trying to educate and get these people to come in. and finding the right provider. Right now, someone who's very smart is able to tease and triage the patient and figure out he's doing a lot of initial workup, including thyroid, inflammatory markers, and that helps figuring out what the patient needs. Now, we don't necessarily have a live multidisciplinary team, but he has the access to an endocrinologist. Can he buy into his endocrinology colleague? Can he buy into his pulmonary colleague and say, hey, listen, will you see my post-COVID patients in an expedited manner and take care of them because they are going to have these symptoms? I think that's where I would start. And obviously, collecting the data and seeing what we are doing is helping these people is very important.
Do you think that the initial outreach could be done by a trained person who's not a physician? Or
I absolutely think so. Like a case coordinator or what we call here a case coordinator would be perfect.
Okay, great. So in the interest of time, I'm going to throw some questions at you. So Dr. Vikram Dayal wants to know, Dr. Dayal, I'm going to call on you to share your experience with ivermectin on long COVID. And I'm going to request Dr. Subramani to respond. Vikram? If you're there, you have to speak up. Okay, we'll come back to Dr. Yeah, go ahead.
Yeah, I don't know if you can hear me now.
We can hear you.
Yeah, I treated one of my friends who had COVID pneumonia for nearly 3 months before she reached out to me. And her physicians, including the pulmonary people, didn't want to do anything else with it. They just said, you'll just recover on your own. So I looked up some stuff on the internet and I found a preprint that said that, ivermectin might be helpful. And I was very gratified to see that she responded dramatically from somebody who was oxygen dependent, short of breath and everything, and with radiological pneumonia 3 months out, is now recovering and is nearly 95% off of oxygen. So I just wanted to share that experience. I know it's anecdotal, but maybe other people can put it to use, because you really don't have a lot of choices in these cases. And, I appreciate the multimodal therapy because some of them may end up with autonomic dysfunction and what looks like POTS syndrome. But I've also had another patient that developed some sort of neurological disorder. I sent him to the neurologist. He said he's got a demyelinating syndrome post-COVID. And even that guy is recovering with high-dose ivermectin, which I've given for about 3 to 4 weeks.
Okay.
So, Dr. Dayal, thanks for sharing. But, I have read some articles on it. We in our system have not used. I'm a rehab medicine specialist, to be transparent about what I do. When I talk to my pulmonary colleagues, she kind of split the 3 types of patients that she's been seeing with long COVID. One is the very mild shortness of breath, maybe underlying history of mild asthma. They put them on Flonase or some kind of nasal inhaler. They seem to be at a little higher risk for upper respiratory infections, but they feel better. The second one is the one where the PFTs show a little bit of an abnormality. They're more short of breath and they're putting them on steroid inhalers. They may or may not have chest X-ray changes. Then they have this third one, which has severe symptoms, significant PFT abnormalities, ground glass appearances on their chest X-rays, and they are battling on what to do with these patients. And it might be a discussion that we have about ivermectin, but in our COVID recovery center, we have no data on it being used or having any success with that.
So all of this really points to the need for a multi-institution registry, which you and Dr. Kati mentioned. So, and I'm just going to move the discussion along. Dr. Geetanjali Sharma had something to say about ophthalmological presentation. Dr. Sharma? Are you able to speak up, please?
Yes, sure, I can speak. Thank you very much for inviting. What we ophthalmologists are seeing in post-COVID or in long COVID patients is there is definitely some blurring of vision, diminution of vision, which improves over the time So reassurance we give, but my question is whether it is due to COVID virus per se, or is it due to steroids used during the treatment, or due to antivirals or antibiotics and all medications that are used? Usually it is seen in young patients, IT professionals, they are not able to work on their screens because of the diminution of vision, and we sometimes have to give different glasses, different power glasses to them. So my question is that.
Yeah.
Yeah,
And
so
as a supplement to that question, I'll request Dr. Monica Naik Nimbalkar. She talks about a similar issue. Dr. Monica?
Yes, I have seen a couple of patients who have recovered from COVID, but I've observed they were not admitted, they were home quarantined and not much on medication, but they have developed now viral conjunctivitis and with few hemorrhagic spots. So is it a new entity or it is connected to the COVID episode they had 2 months earlier?
Thank you. Do you have a comment, Dr. Subramani?
So again, like I told you, we are seeing it is hard to make that correlation at this point. Most of our patients have not had severe infections, haven't been treated with high dose steroids. I have seen a few people with blurred vision, but like you said, they recover over a period of time. They do not have any structural damage, or I mean, sometimes you're looking for some vascular bleeds that might be causing that, but we haven't seen any of that. And you're seeing an increased incidence of these, and they have had COVID. So you're putting 2 and 2 together. I think we have to collect more data to figure out if this is actually a post-viral syndrome.
Thank you.
Like I told you, my ENT colleague was talking about increased incidences of labyrinthitis and tinnitus in his patients who've had COVID.
Thank you. Dr. Chitalkar, you have a question. Prakash?
Oh, yeah. Actually, it's about the second wave has actually involved mostly the younger population in our country. And they are mostly the physically active individuals. So what is the recommendation of kind of restriction of physical activity? Restriction on physical activity, and for what is the duration typically you recommend? And are there any pulmonary function tests necessary in the interim, say 8 weeks, 12 weeks, 16 weeks down the line?
Yeah, so our philosophy is not restriction of physical activity. It's more of encouraging physical activity that is appropriate for them. So if they are short of breath and they are not on oxygen, they definitely go to a pulmonary specialist and they will get a PFT. If they haven't had a chest x-ray, they will get a chest x-ray if they've had a positive COVID infection. And depending on that, their management will take place. But our physical conditioning and aerobic conditioning, we monitor vitals and pulse oximeter while they are doing their exercises. So our physical therapists are really good, and they have found people who come in with just fatigue, and they have run them on a treadmill, and they found them to be short of breath and desatting and having low pulse ox, and they get referred to pulmonary. We've had them working out with young people with palpitations, and then they would get referred to cardiologists. So we have, what we do is usually our speech therapists and pulmonary would do at 60% max heart rate and also monitor oxygen. So the rate of activity is going to be based on these vitals. So we don't want them to drop their oxygen levels below 90. So one of the patients I had was 35 years old, used to run 5 miles every day. That was her thing. And then she would come, take a shower, and go to work. So she got COVID. She had significant fatigue and deconditioning. And she did physical therapy with us for 4 weeks and started feeling really good. And she said, "Doc, I just went for a run yesterday and I ran 3 miles and collapsed." So she hadn't run at all. She was feeling really good and she decided to run 3 miles. But this was a lady who could run 5 miles without thinking about it. So she had to increase her activity progressively and monitor. And a lot of our folks now have pulse oximeters at home, so they monitor that. So that's the basis we do. We try to get them back to being active, but also follow their vitals closely. I hope I answered that.
Yeah, thank you. Thank you, Dr. Chitalkar, for the question. Dr. Padmanabh Keskar has a question.
Hey everybody, myself Dr. Padmanabh Keskar, emergency management expert. So I have 2 questions actually. One of my patient who developed COVID in the last year, October last year, and he developed stroke a day before yesterday. Okay, actually his age is 45 years, no comorbidity other than the history of COVID, and he developed COVID this year. That means almost 9 months after his COVID disease. So my first question is regarding this: how much duration you consider for a post-COVID complication? That means the patient will suffer for how much duration in his after his disease is the first question. And my few patients died due to say COVID complication or post-COVID complication after their RT-PCR test turned negative on day 14. Later on, they developed myocardial infarction or stroke and they died. So these kind of deaths, that means when patient have completed his 14 days of duration of recovery and then they died purely due to COVID complication or post-COVID complication. Can these deaths are labeled as COVID deaths? That means what we figure see in our newspapers regarding the number of deaths of the COVID. So these deaths are registered as a COVID death or they are not registered as a COVID death?
That's a good question. So as I told you, the definition is evolving. So first, let's talk about your first patient. 9 months post without any comorbid factors, getting a stroke, and we know about vascular syndrome. So I have a guy who works for the state of Connecticut as a maintenance worker, very tough, big guy, had COVID, was admitted to the hospital for 2 weeks, got discharged, and 1 month later developed DVT in his leg and a left hemiparesis. Fortunately for him, he did not have any MRI evidence of an actual CVA, whether it was ischemic or not. So the same thing, I'm going to think that without seeing this patient, patient 9 months later developing this syndrome is probably COVID. Because right now the definition keeps extending. We are now seeing patients 9 months post-COVID with symptoms. So I'm going to probably put that person in the post-COVID criteria. Now, we know a lot of these people are recovering and then they get symptoms and it's very inflammatory. That's why we are doing the inflammatory markers. So you can have inflammation of the thyroid, you can have inflammation of the pancreas, you can have inflammation of the heart, especially if they have underlying heart conditions. So myocarditis is common, thyroiditis is common. So those patients that you are saying got discharged and were COVID negative would come into the post-COVID, I'm going to call them post-COVID complications. Because they were COVID negative, according to what you said, right? Sir?
Dr. Keskar, they were negative,
yes,
right?
Yes. They were negative, yeah. But their death was ultimately related to the COVID. But they died, say, on the day of 16, day 18. And my question is regarding this death count. What we see, every nation has their death count due to COVID. So these deaths are counted as a COVID death or they are not counted as a COVID death?
Dr. K, you're going to correct me, but I think most of the acute COVID admissions are the ones that are considered as COVID deaths.
Yeah, and ICMR has guidelines on, the COVID deaths, and it's fairly broad. I don't have the precise definition, but you don't even have to have an RT-PCR to call it a COVID death. Dr. Shinde is.
Can I pitch in there?
Yeah, go ahead, please, Nandita.
Can I pitch in there?
Yeah, please.
So basically, as long as it turns out to be RT-PCR negative, it is taken as far as our death certificates are concerned.
Sorry, Nandita, you're just breaking up.
You're breaking up, Nandita.
Yeah, that's all.
Okay, thank you. And Dr. Chitalkar, we haven't seen, even in bone marrow transplant patients, prolonged problems with COVID, but that's pediatric, right? And perhaps the experience in adult patients is different. So have you seen prolonged cytopenias in your leukemia patients?
In fact, they're seeing long cytopenias in the 25 and the 30-year-olds post-acute leukemias, chemotherapy, or even post-transplant. So that
I see.
I was just wondering whether it's a similar experience in the US.
Not in pediatrics, at least we haven't seen that, but perhaps we just haven't seen enough of those. Thank you. Dr. Kati has some perspective she wants to share, I think. Dr. Lekha? You're mute right now.
I missed the point.
You were making some comments on the chat and I was just.
Yes. Variety. I was just adding my the unusual things that nobody else has talked about.
Okay. Cool. And other questions? Dr. Mohan has some comments on emerging data on long COVID in children. Dr. Mohan?
Yeah, there's just some recent data that's coming out. There's a paper in Acta Pediatrics that seems to suggest that even after 120 days of initial diagnosis, the children have had some impacts, including insomnia, a wide range of symptoms, as we've heard from Mani in adults. So chest tightness, pain, but 14% of patients. I was just in the process of getting the actual reference up to in the chat. So that's just something that we'll be watching for over the next several weeks and coming months. Yes. Thanks.
Thank you. And Dr. Kinjal, any comments? I see that you posted a number of things. Yeah. Do you have any comments to add, Dr. Kinjal? Shindra?
Not really, sir.
Okay. So I know.
Can I ask one question, sir?
Go ahead, please.
Yeah, I'm Dr. Meenakshi Deshpande. I'm a practicing gynecologist. One case was just discussed of PCOD with increasing weight and ovulation dysfunction. So yes, nowadays we are getting many such cases who were COVID positive, and they are now, coming for treatment for PCOD and also for infertility. So how long we do advise them to wait for the COVID, post-COVID symptomatology to develop before we advise them to go in for an infertility therapy? In India here, we are advising about 6 months waiting after becoming COVID positive and recovering from COVID so that they can start their treatment for infertility. So what is your opinion, sir?
So, you can say 3 months, you can say 6 months, you can say 9 months, you'll still be right because we still don't know. But I think 6 months is a pretty safe distinction to start your treatments at this point.
Yeah. Okay.
Okay. So at the end of 6 months, do we need to do any tests for them? Because what they ask is they don't want to take any risk. Do we advise them any tests for just confirming that they are now totally out of the danger of COVID?
I don't think we have anything at this point that we can screen and say you're completely clear of COVID or any of the, I don't think there's any screening test that we have that can give you 100% confidence that they're out of the danger there.
Okay, so we just give them a waiting period of 6 to 9 months maybe, and then we can start their IVF treatment or infertility treatment, whatever is required.
Yeah, we are doing bone marrow transplants. We're treating cancer, much sooner than that. So I think that, I think it should be completely okay. Does anybody else think?
May I?
Yes, please.
I don't see active COVID-19 cases, but I see many post-COVID-19 or the long COVID-19 as has been labeled now. A fair percentage of these patients are also those who have iatrogenic problems. For instance, in the north, in and around Delhi, supraphysical. Can you hear me?
Yeah, just speak up a little bit louder, Shekhar. Sorry,
laptop I'm coming. Okay.
Yeah.
So inappropriate treatment with the large dose of steroids for long periods, and these are patients with side effects. I've seen every now and then I see a patient who has severe hypokalemia, which has remained undetected, and patient has extreme fatigue and all that. So many cases in the north, which are a direct consequence of very tail of inappropriate treatment, which is not being talked about much. That's one thing. Second is many of these sequelae have been described earlier, now also. For instance,
program morning Wednesday. Eco.
Am I audible?
Yeah.
Okay.
Can everybody mute their mic except the person who is
Dr.
speaking?
Gurti,
That would help
please,
a lot.
thank you.
Okay.
All right, Shekhar, please go ahead.
One was consequences of inappropriate treatment. Second is other sequelae which are well described in the aftermath of Spanish flu, call it encephalitis lethargica or post-viral fatigue syndrome or teeth syndrome, the costochondritis, which I see every now and then. I see 2 or 3 patients in an OPD who have localized tenderness on in costochondral joints. And if they have had PCR positive COVID-19 illness, this thing remains in their mind that possibly COVID-19 is still hiding somewhere, and then a lot of functional overlay. My wife, who's director of an ICMR institute, NICPR, they have possibly the country's largest lab. They do close at peak, they did 10,000 PCR tests every day. Now, 5 or 6 scientists or technicians have developed COVID-19, and all of them have long COVID syndrome. Initially, I thought that it was just functional overlay, but one of them turned out to have hypokalemia, 2 have costochondral visible swelling and tenderness. So many of these are not simply functional overlays. That's all I have to say. Thank you.
Thank you. Thank you. So in the interest of time, and people have to go to work in India, I would request Dr. Mani to give us a little summary on sort of a take-home message for, where do we go from here? And so succinctly, please, Dr. Mani.
One is I'm really thrilled to see how well it's recognized by folks in India. I know you guys were in the throes of acute COVID, and I'm so ecstatic to see that you are recognizing post-COVID and you are seeing and treating these patients. And we are seeing a variety of symptoms from gynecological, neurological, and I agree with Dr. Katti about these people are also immunocompromised. And I think we need to share our data because you have a lot of interesting cases, more in the infectious origin. And we have a lot of data here from a vascular standpoint, from a psychological standpoint, and ultimately, hopefully in the next year or so, we will come to a point where we can figure out what is post-COVID, who does it affect. I think people with comorbidities are at a higher risk. I think it still in this country holds good for African Americans and Hispanics being at a higher risk. I am 100% sure that the psychological aspects of the illness are on people with underlying premorbid history of anxiety that are having problems. And obviously the folks with asthma seem to have a lot more shortness of breath and symptoms post COVID. But this is an interesting virus. We are learning every day, as we say, and I'm so glad that we are able to connect, and hopefully together we'll make things better for these patients as they move
Thank
on.
you. So you outlined how we could actually start a, like a COVID clinic, phone number, WhatsApp, some follow-up that like places like Bharati Vidyapeeth are already doing, and using, trained personnel, who are not physicians to do the initial screening. So very important point that Dr. Mokhtar has just made. Dr. Mokhtar, do you want to say this? This is a very important question that must be heard. Dr. Mokhtar?
Yes, sir. Actually,
go ahead.
Actually, I'm a public health specialist. I work in the programs. I'm a state nodal officer of Sikkim for this CPHC, Comprehensive Primary Health Care. So we have a lot of cases in the rural area. Diagnostic facilities and doctors are there. So they are looked after by the community health officer. So I was thinking whether there are any thing which has been worked out, COVID cases in these areas, which, you know, symptoms which they can early, so that they can be referred to higher center, because these people, I feel many of them are there in the rural areas who really actually require this help.
So Dr. Mani, this is a very important question, please.
So I'm going to say most access to very minimal labs that we do as a screening. I have to look at, from an Indian standpoint, from your experience, I'm going to say they were COVID and they are having shortness of breath, and any kind of weakness. If they have swelling in their legs, these are things that could indicate that maybe there's a vascular problem. They're having any kind of hemiparetic. It's all clinical exam, right? At that point in the rural side. So if you have a left-sided weakness or a visual, then that's a sign that there's a neurological issue going. If they are short of breath with activity in a rural area, you're walking around and you're short of breath and you're having difficulty, and if you're having chest pain, one of the things we do at our COVID recovery centers in with chest pain, we are all saying, this is COVID, this is COVID. That could just be an event like an angina. So we have to make a assessment, whether or by seeing the patient and saying, you need to go to the ED because this is not a post-COVID having a acute MI or an anginal episode. So we should just make a clinical screen and divide on who's just having mild symptoms versus someone who's significantly short of breath neurologically, or being lethargic, or having some cognitives that bring up alarm bells that you have to get them at a bigger facility. Does that help?
Thank you. Thank you
very much. So Dr. Mokhtan, so I hope that your screening survey, intake survey, would that be useful to be disseminated?
Yes, actually what we are doing is we are planning to start a post-COVID care for we are collecting the data. We have all the number of cases. So we are planning to launch a training program for the community health officers in rural areas, so that they can find all the signs and symptoms and follow for at least 3 months.
Okay. Thank you. I want to also ask Dr. Mani if the screening intake survey, would that be a good model for a primary health worker to use for screening?
I could definitely share it with you, Dr. Mokhtan, but it might be a little bit of resources that you might. I will kind of send it out. I'll just underline some possible to be done, but looking at just clinical screening aspects that you diagnose whether it's a serious case or not. I'll be happy that with you.
I'm going to request Dr. Shinde in the end. Go ahead, Dr. Mokhtan.
Oh, actually, will be our technical assistance for rolling out this program. So, planning to roll it out this week or by next week's time.
Jhpiego have a triage formula for you guys? Have they shared? Are they working with you on that?
Yes, working with us, but it has not been finalized. First, we will be in launch, be working out all the nitty-gritties, the science and so till and things like that. And before I end, I just want to say that I have been attending this this webinar for quite some time, and I find it very interesting and helpful. It's a clinical part, more of a clinical part, but for us, in the programs in the rural setting, like when we hear these things, then arrange and make our programs better. So I really thank the organizers. Thank you.
Thank you.
Dr. Mokhtan, if you can share your draft proposal, I'll be happy to look at it and help you with it, if you feel like I can add something to it.
So I'm going to invite the Jhpiego people to step in here, because this was one of the things in Pune, for instance, from Dr. N.S. Mani, at Bharati Vidyapeeth is, this one of the things that to think about long COVID. And role briefly, Dr. Shinde, do you see moving forward? And then some people are asking about the video being on YouTube and things like that. Dr. Shinde?
Yeah. So these sessions are being recorded and available on YouTube, Operation Breathe Pune channel. I'll share the link in the chat box now and also in the WhatsApp group. So we have received around 11 responses from the participants, mostly are from the Pune, and some of them have shown interest for the long COVID. And we'll see once we get responses by end of this week, how we can connect them and find a nodal center at the Bharati Vidyapeeth and start this on a project basis.
This is Suranjan here. This is about, so we are working with 4 to 5 states, largely in the Northeast and in Jharkhand places, where we're just creating a kind of a digital architecture to storing data. Now, what data needs to be captured and how, when and how, I think we're still looking for experts to advise us on. What we're only saying is, I think there's going to be a vehicle available soon, keep collecting data. And I think we need to now work together and synergize efforts.
Yeah, I think we had, 2 people who really gave very good perspectives on a large number of cases, both Dr. Purandare and Dr. Subramanian. So hopefully we'll go forward and we can have more discussions to move forward. Any final thoughts, anybody? I want to make sure that anybody who's anything to say has an opportunity to say it. And while we wait, next week we'll talk about.
Can I say something? Working guidelines need to be formalized. There's a lot of people, and they can be amended and modified and upgraded as along. Because in the absence of that, now we are not able to give sheltered employment to a lot of people who need it. They're not covered by insurance. They're not. I mean, insurance doesn't recognize it. Employer doesn't recognize this condition. Needs to be formalized in a hurry.
Okay.
Because people are suffering.
This is very, very important. So if anybody's sure that this is an important topic, it's become very obvious that that's the case. Follow up on all of those, and then we hope to meet you all again next week, same time. And we'll talk about pediatric COVID, and then we'll also give you an update on bird. So please go back to the Google forms and respond. And your feedback is really important, and your participation is really important. So with that, thank you very much. Have a good day in India, and have a good night in the US and elsewhere. Much.
Thank you. Good night and good day to everyone.
Thank you. Bye.
Thank you, sir.